Right ventricular outflow tract obstruction with hypertrophic cardiomyopathy would favor a diagnosis of A. Danon disease, B. Anderson-Fabry disease, C. Noonan syndrome, D. Pompe disease. Correct answer C. Noonan syndrome. Even though increased thickness of right ventricular free wall can occur in both Anderson-Fabry disease and Noonan syndrome, RVOT obstruction along with HCM is characteristic of Noonan syndrome. Dynamic LVOT obstruction can occur in A. Hypertrophic cardiomyopathy, B. Calcification of posterior mitral annulus, C. Hypovolemia, D. All of the above. Correct answer D. All of the above. In addition to these, dynamic LVOT obstruction can also occur in hypercontractile states and sometimes even in hypertension. Coved ST segment elevation in lateral leads in hypertrophic cardiomyopathy is suggestive of A. Lateral wall myocardial infarction, B. Apical aneurysm, C. Coronary vasospasm, D. None of the above. Correct answer B. Apical aneurysm. Coved ST segment elevation in lateral leads in hypertrophic cardiomyopathy can be due to small apical aneurysm formation in those with apical or distal hypertrophy. This can be associated with myocardial scarring. The small aneurysms may only be detected by cardiac magnetic resonance imaging, contrast ventriculography, or myocardial contrast echocardiography. Northwest QRS axis in hypertrophic cardiomyopathy is most likely due to A. Fabry disease, B. Noonan syndrome, C. Danon disease, D. None of the above. Correct answer B. Noonan syndrome. In Noonan syndrome, extreme hypertrophy of the basal region of the left ventricle, often involving the right ventricular outflow tract, is responsible for the extreme northwest axis. Diagnosis of hypertrophic cardiomyopathy in a first degree relative by European Society of Cardiology 2014 guideline needs left ventricular wall thickness of A. 15 mm or more, B. 14 mm or more, C. 13 mm or more, D. 12 mm or more. Correct answer C. 13 mm or more. Primary diagnosis, not in a first degree relative, needs thickening of left ventricular wall in any of the segments of 15 mm or more, not explainable by abnormal loading conditions like hypertension or aortic stenosis. The thickness can be measured by any of the imaging modalities like echocardiography, cardiac magnetic resonance imaging, or computed tomographic imaging. In a first degree relative of a person with hypertrophic cardiomyopathy, the cutoff value needed is lower at 13 mm. Strongest risk predictor in hypertrophic cardiomyopathy. A. History of sudden cardiac death in multiple family members. B. Previous cardiac arrest or sustained ventricular arrhythmia. C. Septal thickness more than 30 mm. D. None of the above. Correct answer B. Previous cardiac arrest or sustained ventricular arrhythmia. Septal thickness of more than 30 mm is one of the weakest predictors. Family history of sudden cardiac death is important, more so if there are multiple affected family members. But the strongest predictor of all is a previous history of cardiac arrest or sustained ventricular arrhythmia in the same individual. Pulmonary thromboendarterectomy is the treatment of choice for A. Primary pulmonary hypertension, B. Eisenmenger syndrome, C. Chronic thromboembolic pulmonary hypertension, D. Massive pulmonary embolism. Correct answer C. Chronic thromboembolic pulmonary hypertension. Majority of patients with CTEPH have good relief of symptoms with pulmonary endarterectomy, and surgical mortality is around 5% in expert centers. Responders to surgery have near normalization of hemodynamics. Non-responsiveness could be due to the presence of pulmonary microvascular disease. The procedure is done under deep hypothermia and circulatory arrest. Pulmonary endarterectomy is done through the medial layer of the pulmonary arteries and is different from the surgical embolectomy done for acute pulmonary embolism. Only thrombi in main, lobar and segmental pulmonary arteries are accessible. Only those in NYHA functional class 3 to 4 are considered for this truly major surgery, which takes several hours to perform. Most important complication after alcohol septal ablation for hypertrophic obstructive cardiomyopathy is A. Heart failure, B. Incomplete resolution of left ventricular outflow gradient, C. Complete heart block requiring permanent pacemaker, D. None of the above. Correct answer C. Complete heart block requiring permanent pacemaker. Alcohol septal ablation is popular in Europe as a less invasive form of septal reduction therapy than surgical myectomy for relief of left ventricular outflow obstruction in hypertrophic obstructive cardiomyopathy. But the procedure has a 7 to 20% risk of permanent atrioventricular block requiring permanent pacemaker implantation. But the risk has been significantly reduced by using intra-procedural myocardial contrast echocardiography to assess the territory of supply of the septal branch of left anterior descending coronary artery. Riociguat used in the treatment of pulmonary arterial hypertension is a phosphodiesterase 5 inhibitor, B. Soluble guanylate cyclase stimulator, C. Endothelin antagonist, D. Calcium channel antagonist. Correct answer B. Soluble guanylate cyclase stimulator. Riociguat is a novel drug for the treatment of pulmonary arterial hypertension with a dual mode of action. It acts along with endogenous nitric oxide as well as by stimulating soluble guanylate cyclase by a mechanism independent of nitric oxide. It has been evaluated in Patent 1 and Patent 2 trials. Please don't forget to subscribe to this channel for future updates and click on the bell icon for all updates. Thank you.